Hello everybody, welcome back to my channel. This is Dr. Ipshita. Let's talk about Myasthenia Gravis. So we'll cover Myasthenia Gravis in three videos, three parts. Today let's talk about the pathogenesis and the manifestation of this disease. So what is Myasthenia Gravis? It is a disorder caused by an antibody-mediated autoimmune attack on the acetylcholine receptors at the neuromuscular junction. So, what is the hallmark of this disease? It is a fluctuating muscle weakness. That means the weakness worsens with exertion and it improves with rest. It is not constant. Annually, 8 to 10 cases of myasthenia gravis are found per million population. Females are twice more frequently affected than males. The disease has two peaks. The first one is in the second to third decade, affecting more commonly women. And in the 6th to 7th decade is the second peak where men are more often affected. The younger patients more commonly have a thymic hypoplasia and are associated with HLA-B8 and HLA-DR3. Whereas patients who are older than 40 years have a more common association with HLA-B7 and HLA-DR2. So first let's understand a normal neuromuscular junction. So a neuromuscular junction is composed of a motor axon terminal, the synaptic cleft and the postsynaptic surface of the muscle cell. Acetylcholine mediates this neuromuscular transmission. It is stored in vesicles in the cytoplasm of the nerve terminal. Then action potential develops, depolarization of the axons occur, which leads to release of acetylcholine into the synaptic cleft by a calcium-dependent, voltage-dependent exocytosis. Acetylcholine after that diffuses across the synaptic cleft to the postsynaptic folds. So these postsynaptic folds contain acetylcholine receptors at the tip of the folds. And acetylcholinesterase is present deeper within the synaptic folds. When two acetylcholine molecules bind to a receptor, a conformational change occurs and an ion channel opens, resulting in a local depolarization and subsequently muscle contraction. So here, a action potential develops in the nerve. The calcium channels have opened and calcium enters. Acetylcholine, which is present in the vesicle at the nerve end, undergoes a voltage mediated exocytosis and enters the synaptic clefts. Now at the postsynaptic region, these are our acetylcholine receptors which are present at the tip, whereas acetylcholinesterase is present in the folds. Now, the released acetylcholine comes to the synaptic cleft, and when two molecules attach to a receptor, ion channels open, and this results to an action potential in the muscle which results in muscle contraction. This is how a normal neuromuscular junction acts. Now, what is the pathology in myasthenia gravis? What happens here is at the postsynaptic membrane, there's loss and simplification of the postjunctional folds. The number of acetylcholine receptors are reduced and there's a widened synaptic cleft. New receptors are synthesized, but they are not incorporated into the damaged postsynaptic membrane. This results in reduction of number of receptors to 1/3 the actual number. So with a reduced number of receptors, the end plate potential is inadequate to generate contraction of some muscle fibers. This produces the characteristic muscle weakness. As we can see here, this part remains same. The nerve action potential develops, calcium enters, acetylcholine is released. But as we see here, the number of acetylcholine receptor is reduced. And there's a loss and simplification of the post-junctional folds, and the acetylcholinesterase is also present right here, so degradation also occurs more. This is the neuromuscular junction in case of a patient with myasthenia gravis. So why is this muscle fatigability occurring? That's because even in a normal person, a decline, that is what we call a rundown, occurs in the amount of acetylcholine that is released by successive muscle contractions. Now at myasthenic junctions, there's already reduced number of receptors, and now due to the rundown, the acetylcholine released is reduced. So there's a progressive failure of this neuromuscular transmission. That is why the muscular fatigability worsens with exertion and improves with rest, which is the hallmark of this disease. This is the autoimmune disease. So the abnormality, muscular abnormality is occurring from an antibody mediated process which likely originates in the thymus gland. So these antibodies, they accelerate the rate of degradation of the acetylcholine receptors. They also block the acetylcholine binding sites. B cells produce the antibodies. T cells are also an important part in the autoantibody response of myasthenia gravis. So both B and T cells take part, but B cells are more important. In myasthenia gravis, T and B cells produced by the thymus gland are more responsive to the acetylcholine receptor compared with the counterparts in the peripheral blood. So what are the ocular manifestations? Ptosis and diplopia. They're present at the onset in about 70% of patients and eventually are present in 90%. Ptosis can be isolated or associated with extraocular muscle. Often, ptosis can be the first symptom of myasthenia gravis. It can be unilateral or bilateral. In bilateral cases, it can be symmetrical or asymmetrical. It is often more pronounced as the day progresses. Diplopia can be a single muscle paresis or due to total ophthalmoplegia. It can simulate ocular motor nerve palsies, unilateral or bilateral internuclear ophthalmoplegia, or gaze palsy. LPS also is involved. If when LPS is involved, the disease may mimic a pupil sparing third nerve palsy. The diplopia usually fluctuates throughout the day. Sometimes it can have a vertical separation, sometimes a horizontal separation. The diplopia is usually intermittent in nature. Nystagmus can develop due to muscle fatigues. Usually, the pupils are normal in myasthenia gravis. That helps to differentiate from a nerve palsy. So, we will talk about the diagnosis and the treatment part of myasthenia gravis in the subsequent videos. If you found this video useful, please hit the like button, share it with your friends and colleagues, and subscribe to my channel if you already haven't. I hope this was useful. Thank you.